Welcome to the Deep Dive, where we extract the most important nuggets of knowledge and insight from a stack of sources, giving you a shortcut to being truly well-informed. Today, we're tackling an organ that, well, for centuries, was mostly dismissed as a biological leftover. Think of it like that dusty old spare tire in your garage. You hope you never need it, and, if it causes trouble, you just get rid of it. We are, of course, talking about the appendix. For a long time, if it acted up, the solution was pretty straightforward. Out it came. But as we'll discover today, there's so much more to this tiny organ than meets the eye or perhaps the surgeon's scalpel.
It's really striking, isn't it, how our understanding of something seemingly simple can evolve so dramatically with new research and clinical insights. It truly challenges our preconceptions and, pushes the boundaries of medical knowledge.
That's a powerful point. Today, we're embarking on a comprehensive, elite-level deep dive into the appendix. Our mission for you, our dedicated listener, is to provide such a thorough understanding that you'll master every concept, giving you the confidence to feel truly well-informed, like a professional in the field. We're going to unpack its surprising history, delve into its intricate anatomy and often misunderstood function. We'll tackle common and urgent ailments like appendicitis and even explore some of the rarer, more complex conditions it can harbor. And to ensure that elite understanding, our entire exploration today is rigorously sourced from the definitive medical text, SCHWARTZ's Principles of Surgery. So let's get started. It's incredible to think how far back our understanding of the appendix goes. I mean, even before modern surgery, before we had any real grasp of sterile technique or anesthesia, anatomists like the incredibly influential Andreas Vesalius and, well, the legendary polymath Leonardo da Vinci were already meticulously charting the human body.
That's right, and their work was incredibly detailed for the time.
And guess what? Their detailed observations included the appendix. This wasn't some recent discovery. It was present in their earliest maps of human internal landscapes.
And this journey from just observing it to the first successful intervention is truly remarkable. The very first documented successful appendectomy was performed by a surgeon named Claudius Amiand. That was back in the early 18th century.
Wow, the 18th century. That's amazing.
Imagine in that era successfully performing such an intricate operation with the tools and, limited knowledge they had. It was a truly groundbreaking feat for its time, especially when you consider the complete lack of advanced surgical instruments or a real understanding of how to prevent infection.
And then we fast forward a bit to 1889, and a true game changer arrives. Chester McBurney. He famously advocated for early appendectomy in his influential publications, which significantly progressed both the diagnosis and, crucially, the management of appendicitis.
That was a huge shift, wasn't it?
Absolutely. It was a pivotal shift from simply watching and waiting for the condition to progress to a proactive surgical intervention. It brought a new urgency and effectiveness to treatment and, well, ultimately saved countless lives.
And the severity of appendicitis, particularly before widespread surgical understanding and the advent of antibiotics, really cannot be overstated. Just consider the famous, or perhaps infamous, story of Harry Houdini.
Oh, right, the magician.
Exactly. The renowned magician, known for his incredible feats of endurance and escape, actually died of a ruptured appendix. His death was reportedly after suffering a blow to his abdomen. Now, this blow didn't directly cause the appendicitis, but it's thought to have exacerbated an existing inflamed appendix, leading to its rupture.
So the timing was just terrible.
Precisely. This anecdote powerfully underscores just how dangerous this condition could be, and frankly still is, when left untreated or diagnosed late.
The narrative then shifts dramatically with another monumental medical leap: the introduction and widespread use of antibiotics in the 1940s.
Oh, absolutely. The advent of antibiotics dramatically improved mortality rates for appendicitis. Before these miracle drugs, a perforated appendix often meant widespread peritonitis, a severe, often fatal infection of the abdominal lining, and a really high likelihood of death. These new medications provided a critical tool in managing the infection, even if surgery was still ultimately required to remove the source.
A massive difference in outcomes.
A profound shift. It transformed a frequently deadly condition into one that was largely treatable.
And finally, a jump to more modern surgical techniques. Fast forward to 1982, a gynecologist named Kurt Sem reported on the first laparoscopic appendectomy. This was a true paradigm shift, moving from large incisions to minimally invasive techniques.
And what's truly fascinating here is how that technique, which was probably met with some skepticism at first, has now become the most widely adopted method for appendectomy today. Laparoscopic surgery revolutionized the approach, offering benefits like smaller incisions, less pain, and quicker recovery times for patients. We'll definitely delve into those details more deeply later in our deep dive.
Okay, so for so long, the appendix was widely dismissed as a vestigial organ, just a biological remnant, right? An evolutionary leftover with no real purpose, destined only to cause trouble. But new understanding paints a very different picture, fundamentally challenging that long-held belief.
It does, and this raises an important question. If it's not vestigial, what is its role? Current research now links the appendix to the development and preservation of gut-associated lymphoid tissue. We often abbreviate that as GALT.
GALT, there you go. Part of the immune system.
Exactly. GALT is a crucial component of our immune system, playing a significant role in defending against pathogens in the gut. Beyond that, the appendix is also believed to play a role in maintaining the delicate balance of our intestinal flora, the beneficial bacteria that live in our digestive system. So it's far from just a passive pouch. It seems to be an active participant in our immune and digestive health.
So what does this all mean for us then? The larger implications of its function. Some fascinating, though, as you said, currently unproven suggestions are that an appendectomy, removing the appendix, might actually be associated with an increased risk of Clostridium difficile infections. That's a nasty gut infection.
That can be very serious, yes.
And there's also a suggestion of an increased subsequent risk for certain cancers, specifically colon and esophageal cancer, potentially due to the alteration in the gut's microbial environment after removal. It's important to stress again, these are currently unproven theories that require more research, but they open up intriguing avenues for future study into the appendix's long-term influence.
And conversely, it's also worth noting that a protective effect of early appendectomy against the development of ulcerative colitis has been proposed.
Ulcerative colitis, one of the inflammatory bowel diseases, so removing it might help prevent that.
That's the theory. Essentially, removing the appendix might alter the gut's immune response in a way that reduces the risk of this specific condition. This level of detail is crucial for mastering the topic because it speaks to the appendix's nuanced involvement in the immune system. It highlights the complex interplay of cells and molecules. It's far more than a simple, inert tube.
Let's trace its beginnings then. Where does it come from embryologically? The appendix, along with the ileum, that's the final section of the small intestine, and the colon, the large intestine, all develop from the midgut, which is a key part of the embryonic digestive tract. And it actually appears quite early in development, as early as 8 weeks of gestation. So it's there from the start, pretty much.
That's right. And as the gut continues its complex development and rotates medially during embryogenesis, the cecum, which is that pouch connected to the large intestine, becomes fixed in the right lower quadrant of the abdomen. This fixation thereby determines the appendix's final common position.
Ah, okay. So that explains why it's usually found there.
Exactly. It explains why it's consistently found in that area for most individuals, leading to that classic right lower quadrant pain we associate with appendicitis.
Now, let's get into the nitty-gritty anatomical details. What makes it unique? It's considered a true diverticulum of the cecum, meaning it's a small, finger-like pouch that extends from the cecum, and importantly, it contains all the histological layers of the colon. Although there are some subtle differences in its microscopic structure, particularly in the irregularity of its crypts, those glandular invaginations in the lining.
Yes, and while its size can vary, the average appendix measures between, say, 6 to 9 centimeters in length. Its blood supply is quite specific, coming directly from the appendicular branch of the ileocolic artery. That's a critical detail for surgeons, of course, as this vessel must be carefully ligated during an appendectomy.
And the nerves. How does it sense things or get signals?
Right. The visceral innervation, the nerves transmitting sensations and controlling involuntary functions, primarily occurs along the superior mesenteric plexus. This carries signals from spinal segments T10 to L1 and also via the vagus nerves. So the key takeaway from those intricate nerve connections, it explains why early appendicitis pain can be so deceptive.
Deceptive how?
Well, it often starts vaguely in the periumbilical region, around your belly button, before it settles into that sharp localized pain you expect in the right lower quadrant. That's due to the shared nerve pathways initially.
Its precise location within the abdominal cavity also has clinical significance, doesn't it? It's not always in the same spot.
Not always textbook, no. While it is typically intraperitoneal, meaning within the peritoneal cavity, and often retrocecal, meaning behind the cecum, its position isn't always predictable. It can be pelvic, lying down in the pelvis, in about 30% of cases.
30%. That's quite common.
It is. And it can be retroperitoneal, meaning behind the peritoneum, in about 7% of cases. These variations can definitely make diagnosis more challenging as they affect where the pain is felt, sometimes mimicking other conditions like gynecological issues or even kidney stones, depending on where it's sitting.
So how do surgeons find it reliably during an operation?
Well, to identify the appendiceal base grossly during surgery, surgeons typically trace the convergence of the cyclotetania. These are three distinct longitudinal bands of smooth muscle on the outer surface of the large intestine. As they converge, they point directly to the appendix, making it a reliable landmark for precise surgical removal. This detailed understanding of its embryology, anatomy, and histology is truly fundamental for anyone aiming for that elite understanding of this organ.
Okay, moving on to the most common and certainly the most urgent condition associated with this organ. Acute appendicitis. This isn't just a medical curiosity. It's a significant public health problem globally. Its lifetime incidence is surprisingly high. It affects 8.6% of men and 6.7% of women.
That's a considerable portion of the population.
It is. And the highest rates occur in the second and third decades of life. So it's quite prevalent, especially among younger adults and adolescents.
And while the actual rate of appendectomy in developed countries has decreased somewhat over recent decades, potentially due to better diagnostics or maybe changes in incidence, it still remains one of the most frequent emergent abdominal operations performed worldwide. This just highlights its continued clinical importance as a common cause of acute abdominal pain requiring urgent surgical intervention. It's a condition that every physician, especially those in emergency or surgical fields, must be adept at diagnosing and managing. It's bread and butter, really.
So what exactly causes appendicitis? Can you walk us through the basic mechanism?
Sure. The primary cause, the root issue, is almost always luminal obstruction.
Meaning something blocks the inside of the appendix.
Exactly. Something blocks the narrow opening or the lumen of the appendix. This blockage traps bacteria and mucus inside, leading to pressure buildup and inflammation.
And I imagine the specific causes of this obstruction can vary. It's not always the same thing blocking it.
Precisely. In pediatric populations, this obstruction is often due to lymphoid hyperplasia. That's basically an enlargement of the lymphatic tissue within the appendix wall, which is common in children as part of their developing immune system.
Okay, so in kids, it's often their own tissue swelling up. What about adults?
For adults, the causes are more varied. It can include fecaliths. These are hardened pieces of stool, sometimes called appendiceal stones. It could also be fibrosis, which is scarring, or foreign bodies like undigested food particles, maybe seeds, parasites, or even calculi, which are small stones. And more seriously, especially in older patients, we have to consider neoplasia, the growth of a tumor, as a cause of obstruction. That's a critical consideration.
Right. So once that obstruction happens early on, it sets off a rapid cascade of events. It leads to bacterial overgrowth, you mentioned.
Yes, rapid bacterial overgrowth. Initially with aerobic organisms, but then it quickly progresses to a mixed flora, including anaerobic bacteria. This bacterial proliferation, combined with the ongoing mucus secretion into the blocked tube, increases the intraluminal pressure within the appendix. And that leads to the classic referred visceral pain often felt initially in the periumbilical region, around the belly button.
And that pressure keeps building.
It does. It's postulated that this increasing pressure within the appendix then impairs venous drainage. Blood can't get out easily. This causes a buildup of blood and fluid, which in turn leads to mucosal ischemia, essentially a lack of blood flow and oxygen to the lining of the appendix.
And that damaged lining lets bacteria escape.
Exactly. This damage allows for bacterial translocation, where bacteria escape from the appendix lumen into the surrounding tissues and even the bloodstream. Ultimately, this can lead to gangrene, which is tissue death, and then potentially to a full-blown intraperitoneal infection if the appendix ruptures or perforates. For professionals listening, it's a critical detail to know that Escherichia coli and Bacteroides fragilis are the most common aerobic and anaerobic bacteria isolated in cases of perforated appendicitis. Knowing the likely culprits helps guide antibiotic choices.
Interestingly, though, the natural history isn't always a straightforward progression to rupture, is it? You mentioned earlier that some episodes of acute appendicitis can actually resolve spontaneously without intervention.
That's a fascinating point, and it complicates the picture somewhat. Yes, some episodes can resolve. This observation suggests that non-perforated and perforated appendicitis might actually be different diseases, or at least represent different ends of a spectrum with potentially distinct pathogenic pathways.
Why is that distinction important?
Well, given their epidemiological differences, they affect slightly different age groups and have different risk factors, and the crucial fact that not all non-perforated cases necessarily progress to perforation. It indeed suggests that the pathogenesis, the way the disease develops, might be distinct. This understanding is really key as we start reevaluating traditional management strategies, particularly when we get into the debate around non-operative management with antibiotics versus automatic surgery for everyone.
Okay, so when a patient presents with acute abdominal pain, the first step is crucial, getting an accurate history. This is especially true for pediatric patients, right? Where family input is often vital in piecing together the timeline and symptoms.
Absolutely essential. The history is paramount. As the inflammation progresses, it often moves from the visceral peritoneum, which covers the appendix itself, to involve the parietal peritoneum, which lines the abdominal cavity. This progression classically presents with that migratory pain we talked about, starting vaguely in the periumbilical region and then localizing to the right lower quadrant. This migratory pain is a key diagnostic clue, actually. It has a likelihood ratio of 2.06, meaning it significantly increases the probability of appendicitis.
What other symptoms are common?
Other common symptoms include anorexia, so loss of appetite, nausea, sometimes vomiting, and usually a low-grade fever. Regional inflammation can also cause related issues like an ileus, which is a slowdown of bowel movement, or less commonly diarrhea, small bowel obstruction, or even hematuria, blood in the urine if the inflammation irritates the nearby bladder or ureter.
And it's important to ask about things that aren't happening too, right? The pertinent negatives.
Critically important. For instance, asking about menstrual history in women of childbearing age is absolutely essential to rule out other gynecological causes of pain, like an ovarian cyst or ectopic pregnancy.
Then comes the physical examination. It's fascinating how the body tells its own story here. Most patients with parietal peritonitis, that inflammation of the abdominal lining, they tend to lie quite still, don't they? Because movement exacerbates their pain.
Exactly. They often guard instinctively. They typically have that low-grade fever, usually around 38.0 degrees C or 100.4 degrees Fahrenheit, and they exhibit focal tenderness with guarding in the right lower quadrant where the muscles involuntarily contract to protect the inflamed area underneath.
And there are specific points and signs surgeons look for.
Yes, several key signs. McBurney's point, which again is found 1/3 of the distance between the anterior superior iliac spine, that bony prominence on your hip, and the umbilicus, belly button, is often the site of maximal tenderness in a patient with an anatomically normal appendix position. Beyond that, several eponymous signs help localize the appendix, which is vital for clinical diagnosis, especially if the appendix is in an unusual spot.
Can you give us examples?
Sure. Rovsing's sign, where palpation of the left lower quadrant causes pain in the right, suggests appendicitis. The obturator sign, characterized by pain with internal rotation of the hip, points towards a pelvic appendix lying close to the obturator muscle. The iliopsoas sign, which is pain with flexion of the hip against resistance, indicates a retrosacral appendix, irritating the psoas muscle behind it. Additionally, pain elicited during a rectal exam or a cervical exam in women can also be highly suggestive of a pelvic appendicitis, given its close proximity to those structures.
Okay, so history and physical exam give strong clues. Then we move to laboratory findings. Lab tests help back up those clinical suspicions, right?
They do. Patients with appendicitis usually have leukocytosis, an elevated white blood cell count, typically around 10,000 cells per cubic millimeter. Higher counts, often around 17,000 cells per cubic millimeter or more, are frequently associated with more advanced stages, specifically gangrenous or perforated appendicitis, indicating a more severe inflammatory response.
Are there other blood tests besides the white count?
Yes. Beyond the general white blood cell count, several other biomarkers have been suggested to aid in diagnosis, particularly in predicting perforated appendicitis. These include C-reactive protein, CRP, which is a general marker of inflammation, bilirubin, interleukin-6, IL-6, and procalcitonin. From a practical standpoint, a white blood cell count and a CRP are generally considered appropriate initial lab tests.
And for women?
A pregnancy test is absolutely essential for any woman of childbearing age presenting with acute abdominal pain to rule out an ectopic pregnancy or other obstetric emergencies. Cannot stress that enough. Lastly, a urinalysis can be valuable in helping to rule out other conditions that might mimic appendicitis, such as nephrolithiasis, kidney stones, or pyelonephritis, a kidney infection, which can also cause lower abdominal or flank pain.
Now, imaging. This seems crucial for confirming the diagnosis and avoiding unnecessary surgery. Given that a negative operation rate of less than 10% for males and less than 20% for females, is considered acceptable by many standards. Imaging is frequently used, especially when the clinical picture isn't entirely clear.
Absolutely. What stands out here is that balance. We don't want to miss appendicitis, but we also want to avoid unnecessary surgery. Cross-sectional imaging, like CT or ultrasound, helps significantly in reducing the rate of negative laparotomies where you operate and find a normal appendix.
When is imaging most appropriate?
Imaging studies are most appropriate for patients in whom the diagnosis of appendicitis is unclear based on history, exam, and labs alone, or for patients who are at high risk from operative intervention and general anesthesia, think pregnant patients, the elderly, or those with multiple comorbidities. In these cases, a misdiagnosis could have severe consequences, so confirmation is key. The commonly utilized imaging modalities include computerized tomography, CT scans, ultrasound US, and magnetic resonance imaging, MRI.
Let's start with the workhorse for many situations.
Yeah.
The CT scan. It's very accurate, isn't it?
Extremely accurate. A contrast-enhanced CT scan boasts a high sensitivity of around 0.96 and a specificity of 0.96 in diagnosing acute appendicitis. That's very good. What surgeons and radiologists look for on a CT scan includes key features like a thickened appendix wall, generally defined as greater than 2 millimeters. Also, periappendiceal fat stranding that indicates inflammation spreading to the surrounding fat, and it looks like a sort of fuzzy halo around the appendix on the scan. And sometimes you can see an appendicolith, that calcified fecalith within the appendix lumen.
What about the radiation concerns with CT?
That's a valid concern, especially in younger patients. However, it's important to put it into perspective. Typical low-dose CT scans result in an exposure of maybe 2 to 4 millisieverts, MSV, which isn't significantly higher than the average annual background radiation exposure we all get, which is around 3.1 millisV. Furthermore, recent trials have suggested that even lower-dose CT scans, around 2 millisV, while maybe not generating perfectly high-resolution images, do not seem to negatively affect clinical outcomes in terms of diagnosis.
And contrast dye. Is that always needed?
Intravenous contrast is generally preferred in these studies because it enhances the visualization of inflamed tissues, making the appendix and surrounding inflammation stand out more clearly. But it can certainly be avoided in patients with known allergies to contrast or those with significant kidney impairment, specifically a low estimated glomerular filtration rate, usually below 30 millivol/minute. And it's worth noting, several large meta-analyses have consistently suggested that CT scan is generally more sensitive and specific than ultrasound in diagnosing appendicitis in most patient populations.
Okay, so CT is highly accurate. Let's move on to ultrasound, US. No radiation, which is a big plus, but its effectiveness can vary more, right?
That's the trade-off. Ultrasonography has a good sensitivity, around 0.85, and specificity around 0.90 for appendicitis, but generally not quite as high as CT. The technique used is called graded compression ultrasonography. The operator applies gentle pressure with the ultrasound probe to assess the appendix's compressibility and measure its diameter.
What does compressibility tell you?
An easily compressible appendix with a diameter less than 5 millimeters generally helps to rule out appendicitis. An inflamed appendix is usually swollen and non-compressible. Features on an ultrasound that strongly suggest appendicitis include a diameter greater than 6 millimeters, pain elicited specifically when pressing over the appendix with the probe, sometimes seeing an appendicolith, increased echogenicity, brightness of the surrounding fat indicating inflammation, and any periappendiceal fluid collection.
So what are the main pros and cons of ultrasound?
The advantages are clear. It's cheaper, often more readily available, especially outside large hospitals, and crucially, no ionizing radiation. That makes it ideal for children and pregnant women initially. However, its disadvantages include being highly user-dependent. The skill of the sonographer greatly influences accuracy. Its utility can also be limited by factors like obesity or excessive bowel gas, which can obstruct visualization. And frankly, it can be quite painful for patients already experiencing peritonitis when you're pressing on their abdomen. When you compare efficacy directly, referencing data like that in Table 30-2 from SCHWARTZ's, CT generally comes out superior in terms of sensitivity and specificity across multiple large studies.
Okay, and the third option, MRI. Another excellent imaging tool, but with different considerations.
Right. MRI of the abdomen also has high sensitivity, about 0.95, and specificity, about 0.92, for identifying acute appendicitis. Similar accuracy to CT. However, MRI is an expensive test, and it requires significant expertise not only to perform the scan correctly, but also to interpret the complex images accurately. It also takes longer than a CT scan. For these reasons, it's usually recommended in very specific patient populations, where the risk of ionizing radiation from a CT scan is a primary concern. This primarily includes pregnant patients, where minimizing radiation exposure to the fetus is critical, or sometimes pediatric patients for the same reason.
This naturally leads to the question, what else could it be? The differential diagnosis for acute abdominal pain, especially in the right lower quadrant, can be extensive. It needs careful consideration, as many other conditions can mimic appendicitis.
Precisely. Ruling out mimics is just as important as confirming appendicitis. Conditions often confused with acute appendicitis include acute mesenteric adenitis, that's inflammation of the lymph nodes in the abdomen, often seen after a viral infection, especially in kids. We also consider cecal diverticulitis, inflammation of a pouch in the cecum, or Meckel's diverticulitis, inflammation of a congenital pouch in the small intestine. Acute ileitis, inflammation of the ileum or an exacerbation of Crohn's disease, both cause inflammation in that same general area. In women, acute pelvic inflammatory disease, PID, or torsion, twisting of an ovarian cyst or a Graafian follicle are crucial gynecological emergencies to rule out.
And common things like stomach bugs.
Absolutely. Acute gastroenteritis is a very common cause of abdominal pain, though often accompanied by more widespread symptoms like diarrhea and vomiting, and usually without localized tenderness or high fever. Sometimes, even after a thorough workup, no specific organic pathology is identified. To help distinguish these mimics, obtaining an antecedent history of a viral infection can be a key clue for mesenteric adenitis or gastroenteritis. Performing a pelvic exam, including a cervical motion tenderness check in women, is essential. Exquisite tenderness suggests PID. And a detailed menstrual history can help differentiate between appendicitis and conditions like Mittelschmerz, mid-cycle ovulatory pain, typically without fever or leukocytosis, or an ectopic pregnancy, which is a true medical emergency. Mastering these differential diagnoses is absolutely critical for accurate and timely treatment.
Okay, let's shift to treatment. For uncomplicated appendicitis, meaning no perforation, gangrene, or abscess, the preferred approach has traditionally been an appendectomy, simple removal. But this is where the conversation gets really interesting, isn't it? Because new research challenges that standard, proposing a non-operative approach using just antibiotics.
Indeed. This has been a major area of research and debate over the last decade or so. Several recent, large, well-designed, randomized controlled trials and cohort studies have meticulously examined the role of non-operative management using antibiotics, primarily in adult patients initially. In these studies, often designed with non-inferiority as the endpoint, patients with uncomplicated appendicitis confirmed on imaging were randomized to either receive antibiotics alone or undergo an appendectomy, which, interestingly, was often performed as an open procedure in some of the earlier trials. This research has really opened up a significant debate in surgical practice, changing how we think about this common emergency.
So what did the antibiotic treatment typically involve in these studies?
Patients in the non-operative arm usually received a short course of intravenous antibiotics first, typically for 24-48 hours, which is crucial for getting the initial inflammation under control quickly. This was then followed by a course of oral antibiotics, commonly using regimens like a fluoroquinolone combined with metronidazole, or sometimes oral amoxicillin clavulanic acid, usually for about 7 to 10 days total. These regimens are chosen specifically to target the typical aerobic and anaerobic bacteria found in appendicitis.
And what did the results show? Did antibiotics work as well as surgery?
Well, meta-analyses pooling the data from these published trials have provided critical insights into the outcomes. And it's not a simple yes or no answer. They found that a significant proportion, around 26.5%, so roughly 1 in 4 patients in the non-operative group, still ended up needing an appendectomy within 1 year, either due to treatment failure or recurrent appendicitis.
So a quarter of them eventually needed surgery anyway?
Exactly. Furthermore, the rate of adverse events, including things like needing additional procedures or having longer overall treatment duration, was actually higher with antibiotics alone, with a relative risk calculated at 3.18. And perhaps more concerningly, patients who experienced a recurrence after initial antibiotic treatment more frequently presented with complicated appendicitis like perforation the second time around, with a relative risk estimated at 2.52.
That's a significant risk, the recurrence being worse.
It is. These figures are crucial for understanding the potential downsides and risks associated with a non-operative approach. They highlight why it's not a straightforward antibiotics are always better or antibiotics are equivalent scenario.
So given these findings, what are the current recommendations for managing uncomplicated appendicitis? Is non-operative management the standard now?
Not exactly. Currently, while conservative management with antibiotics can be offered to carefully selected, informed patients using a shared decision-making process, where the risks and benefits, including the recurrence rates and potential for complicated recurrence, are thoroughly discussed and the patient actively participates in the choice. It is generally not considered the standard modality of management for uncomplicated appendicitis. Appendectomy remains the gold standard treatment.
Are there specific situations where antibiotics might be preferred?
Perhaps one exception might be for patients with a truly significant phobia of surgery, where the psychological impact of an operation is a major barrier to care, or maybe in patients with extreme comorbidities where surgery carries prohibitive risks, though that's less common for appendicitis. But for most healthy individuals, surgery is still recommended. The long-term societal costs and implications of this conservative strategy, including the potential for recurrent admissions, missed work, and repeat procedures, are still being evaluated and need more comprehensive study. The key insight here for you is that while antibiotics are an option, they come with a significant chance of recurrence, potentially more severe disease if it does recur, and aren't necessarily less complicated overall than upfront surgery.
Okay, so surgery is generally preferred for uncomplicated cases.
Yeah.
But even then, there's a debate about timing, right? Immediate emergent surgery versus slightly delayed urgent surgery. In the urgent approach, patients get antibiotics upon admission and then might wait less than 12, maybe even 24 hours for the operation, rather than going straight away in the middle of the night.
That's another area where practice has evolved. Studies evaluating these two timings, immediate versus slightly delayed within 12-24 hours, have generally not revealed any significant differences in overall outcomes, like perforation rates or complication rates. Those undergoing urgent surgery might experience a slightly longer total hospital stay, simply due to the brief waiting period for the operating room slot. So, currently, delaying surgery for less than 12 or even up to 24 hours is considered acceptable and safe for stable patients with a short duration of symptoms, typically less than 48 hours, and confirmed non-perforated, non-gangrenous appendicitis on imaging. This offers a bit more flexibility in scheduling without compromising patient safety, allowing for more efficient use of surgical resources rather than rushing every single case immediately.
Makes sense. Now let's talk about the surgical approach itself. We touched on laparoscopy earlier. Numerous meta-analyses has compared the two primary techniques, laparoscopic versus the traditional open appendectomy. What are the key differences in outcomes?
Laparoscopic appendectomy, which involves those smaller incisions and the use of a camera and specialized instruments, generally results in several advantages for the patient. These include a shorter length of hospital stay, a faster return to work or normal activities, and significantly lower rates of superficial wound infections. This last point is a major benefit, especially for obese patients where wound healing can sometimes be more challenging with larger incisions.
Are there any advantages to the open approach anymore?
Open appendectomy, performed through a single larger incision, usually over McBurney's point, often boasts shorter operative times, which can be an advantage in certain emergency settings, or if the surgeon is less experienced with laparoscopy. Some studies also suggest potentially lower rates of intra-abdominal abscess formation after open surgery compared to laparoscopy, although this is debated and might depend on surgical technique and whether the appendix was perforated. Interestingly, the overall costs of the two techniques tend to be relatively similar when you factor everything in.
How so? Isn't laparoscopy more expensive initially?
The equipment and disposables for laparoscopy are generally more expensive, yes, but these higher upfront costs are often offset by the shorter hospital stays and quicker recovery times experienced by patients, leading to lower overall healthcare utilization costs. In the United States and many other developed countries, laparoscopic appendectomies are increasingly common and have definitely become the dominant approach for acute appendicitis due to these clear patient-centric benefits.
Okay, standard laparoscopy is king. But you mentioned novel techniques earlier. Where are we with those? The bleeding edge, perhaps?
Right. There's always innovation being explored. 3 novel techniques have been investigated for appendectomy with varying degrees of success or adoption. First, there's single-incision laparoscopic surgery, SILS appendectomy. Here, the entire procedure is performed through a single, often umbilical incision.
Sounds cosmetically appealing.
Intuitively, yes. However, prospective randomized studies have actually not shown it to reliably improve outcomes, including cosmetic ones, compared to standard multi-port laparoscopic techniques. In fact, some studies have even suggested it might have a higher rate of incisional hernia formation at that single, larger port site. So while conceptually neat, its practical benefits haven't consistently materialized, and it hasn't been widely adopted.
Okay, so SILS isn't quite there yet. What about natural orifice transluminal endoscopic surgery, or NOTES? That sounds truly minimally invasive, going through the mouth or vagina.
NOTES is definitely pushing the boundaries. It involves accessing the abdominal cavity through natural body openings to perform the surgery, avoiding external incisions altogether. A meta-analysis looking at NOTES procedures, including appendectomies, did suggest potentially better cosmetic outcomes and perhaps less postoperative pain. However, it's critical to acknowledge that this meta-analysis was based on a very limited number of patients, only 40 in total across the included studies. That makes it really difficult to draw definitive conclusions for widespread use. Key issues that currently limit its widespread dissemination include the persistent risk of luminal contamination, bringing bacteria from the gut or vagina into the abdomen, and the technical challenges of achieving reliable, safe, and optimal closure of the entry site in the enteral or vaginal mucosa. This can lead to complications like infection or leakage. So despite its innovative premise, NOTES appendectomy remains largely experimental and hasn't become a mainstream technique.
Fascinating concept, but practical hurdles remain. And finally, what about the increasingly popular field of robotic surgery? How does robotic appendectomy fit into the picture? Surely this must be the future.
Robotic surgery certainly offers some advantages in various complex procedures. For appendectomy, it allows for highly flexible, wristed motions of the intraperitoneal instruments, potentially offering superior dexterity and ergonomics for the surgeon compared to standard laparoscopy. This might be advantageous in very complex or difficult cases, like severe inflammation or unusual anatomy. However, the technology is extremely expensive, both the initial capital outlay for the robot and the per-procedure costs. Furthermore, most of the current robotic platforms also require larger ports or trocars to insert the robotic instruments compared to the smaller instruments used in traditional laparoscopy, potentially negating some of the cosmetic benefit. Thus, despite its potential ergonomic benefits for the surgeon, robotic appendectomy is also not widely utilized for routine appendectomies. It's largely reserved for specific complex scenarios, perhaps in teaching institutions or in centers that already have a robust robotic program for other procedures where the cost can be amortized. The traditional laparoscopic approach remains the efficient, effective, and cost-conscious workhorse for the vast majority of appendectomies. Okay, let's pivot now to complicated appendicitis. This is a more serious category. It includes cases of perforated appendicitis, where the appendix has burst, gangrenous appendicitis, where the tissue has started to die, and cases where an abscess, that collection of pus, or a phlegmon, a walled-off area of inflammation without frank pus, has formed. These presentations require a different, often more complex approach.
And these patients tend to present later.
Right. Usually, yes. These patients typically present after 24 hours of symptom onset, although it's important to remember that about 20% of patients can present with complicated appendicitis even within the first 24 hours. It's not an absolute rule. They are often acutely ill, can be significantly dehydrated, and frequently require immediate fluid resuscitation and stabilization upon arrival at the hospital, as their condition can rapidly deteriorate into sepsis if not managed promptly.
What happens if the infection isn't contained?
The progression of complications can be severe. Usually, a perforated appendix leads to an abscess that is walled off in the right lower quadrant by surrounding structures like the omentum and bowel loops, the body's attempt to contain the infection. However, if this containment fails or is left untreated, more serious retroperitoneal abscesses can occur, spreading behind the abdominal lining. This can include a psoas abscess, affecting a major muscle in the lower back, causing hip pain and difficulty walking, or even spreading upwards to cause liver abscesses. Additionally, fistulas, those abnormal connections, can form between the appendix area and other organs like the bowel or bladder, or even to the skin. And a very serious, albeit less common complication is pylophlebitis. That's septic thrombophlebitis, or inflammation and clotting of the portal vein, the main blood vessel carrying blood from the intestines to the liver. This carries a high risk of systemic infection, liver damage, and mortality.
So how is perforated appendicitis managed? Is it always immediate surgery?
Not necessarily. Perforated appendicitis can be managed either operatively or non-operatively, depending on the clinical situation. Immediate surgery is necessary in patients who appear septic, those with signs of severe systemic infection like high fever, rapid heart rate, low blood pressure, or altered mental status. You have to control the source of infection urgently in those cases. But performing immediate surgery in septic patients with extensive inflammation and perforation usually carries higher complication rates. Things like postoperative abscesses and intraocutaneous fistulae are more common due to the dense adhesions, inflamed tissues that are difficult to handle, and widespread contamination.
So if the patient isn't septic, what's the alternative? You mentioned non-operative or stage management.
Exactly. What's fascinating here is how the management of long-duration, complicated appendicitis, particularly when there's a well-formed abscess or phlegmon, is often staged. It's not always a one-step fix. Patients are first stabilized through fluid resuscitation and treated with broad-spectrum intravenous antibiotics to control the systemic infection and reduce the inflammation. For long-standing perforations where imaging confirms a well-defined abscess, percutaneous image-guided drainage is often the preferred initial strategy.
How does it work?
It involves using imaging like CT or ultrasound to guide the insertion of a needle or a small drainage catheter through the skin directly into the abscess cavity to drain the pus. This strategy has a good success rate, achieving complete resolution of the abscess and symptoms in about 79% of selected patients. Success rates seem to be higher with lower-grade, smaller abscesses, those that are amenable to certain approaches like transgluteal drainage, a drain placed through the buttock muscle if the abscess is deep in the pelvis, and particularly when CT guidance is used for placement compared to ultrasound guidance.
And when is surgery needed in these staged cases?
Operative intervention, meaning surgery to remove the appendix, is then reserved for those patients who fail conservative management, meaning their condition doesn't improve or worsens despite antibiotics and attempted drainage, or for those who initially present with free intraperitoneal perforation, where the appendix has ruptured openly into the abdominal cavity, causing diffuse peritonitis, rather than forming a contained abscess.
Okay, so for most patients with perforated appendicitis managed non-operatively with drainage and antibiotics, the initial episode resolves.
Yes, in about 80% of cases, the symptoms resolve, the infection clears, and the patient recovers without immediate surgery. However, this leads to an ongoing debate in the surgical community about the value or necessity of performing an interval appendectomy.
Meaning removing the appendix later on.
Exactly. Performing an elective appendectomy usually 6 to 8 weeks after the initial inflammatory episode has completely resolved. This is done when the inflammation has subsided, the patient is stable, and the surgical field is much cleaner and safer.
What are the arguments for doing that interval appendectomy?
Proponents cite a few key reasons. First, they point to the risk of recurrent appendicitis, which occurs in about 7.4% to 8.8% of patients who are initially managed non-operatively. So, removing it prevents future attacks. Second, and perhaps more critically, they highlight the potential for discovering an underlying appendiceal neoplasm, or tumor, in the removed appendix specimen. Relevant benign lesions are found in about 0.7% of interval appendectomy specimens, and malignant lesions in about 1.3%.
1.3% malignant. That's not insignificant.
It's not. That's a potentially missed cancer diagnosis if the appendix is left in situ. Opponents of routine interval appendectomy, however, point to data showing a high incidence of no future events, meaning around 91% of patients experience no recurrence or other appendix-related issues after a median follow-up of 34 months in some studies. They argue that operating on everyone to find that small percentage of neoplasms or prevent that small percentage of recurrences might represent overtreatment for the majority.
So it's balance of risks again.
It absolutely is. This highlights the crucial importance of shared decision-making between the surgeon and the patient before proceeding with an interval appendectomy. You have to weigh the risks of another operation against the potential benefits of finding an occult neoplasm or definitively preventing future appendicitis. The key takeaway for professionals listening is that there's no single, universally agreed-upon answer for every patient with resolved perforated appendicitis. It requires a careful, individualized discussion considering the patient's age, risk factors, and preferences.
Okay, let's talk about the care surrounding the operation itself. Once the decision to operate is made, especially for uncomplicated cases, the patient's journey into surgery typically begins quickly, doesn't it?
Generally, yes. Once the diagnosis is confirmed and the decision for surgery is made, patients can usually be taken to the operating room expeditiously.
Any specific preparations needed?
While resuscitative efforts with IV fluids are important for patients who present with significant dehydration or are hemodynamically compromised, the vast majority of patients with uncomplicated appendicitis can be taken to the OR within a short interval, often within hours of the decision. Placement of a Foley catheter, a tube to drain the bladder, is generally optional for most routine appendectomies. Not strictly necessary unless it's expected to be a long or complex case, or if monitoring urine output is critical. Crucially, though, preoperative antibiotics must be administered intravenously at least 30 to 60 minutes prior to the skin incision.
Why is that timing so important?
That timing is critical to ensure adequate antibiotic concentration in the tissues at the time of incision. This helps to minimize the risk of surgical site infection developing later. It's a key quality measure in surgery.
And the choice of antibiotics differs based on the complexity of the case, right? What are the standard choices for uncomplicated appendicitis?
Absolutely, the antibiotic choice is tailored. For uncomplicated appendicitis, meaning no perforation or abscess, common choices include single-agent therapy with something like cefoxitin or ertapenem, which provide broad-spectrum coverage, including anaerobes. Alternatively, a combination like cefazolin, covering gram-positives and some gram-negatives, plus metronidazole, covering anaerobes, is also very common. For patients with significant beta-lactam allergies, alternative regimens are needed, such as using clindamycin combined with an agent covering gram-negatives, like a fluoroquinolone, gentamicin, or aztreonam. And importantly, for truly uncomplicated cases that are removed promptly, postoperative antibiotics are usually not necessary after the surgery is complete, as the source of infection has been surgically removed. A single preoperative dose is often sufficient.
What about the more complicated cases like perforated appendicitis undergoing surgery? The antibiotic strategy must be different there.
Definitely more robust. In patients with perforated or gangrenous appendicitis undergoing operative intervention, the preoperative antibiotics are essential and must provide broad coverage against both gram-negative bacteria and anaerobes, given the polymicrobial nature of the infection spilling from the gut. Good choices include monotherapy with a broad-spectrum agent like piperacillin tazobactam, or a combination therapy using a third-generation cephalosporin like ceftriaxone, plus metronidazole. The duration of postoperative antibiotics is also a key consideration for complicated cases.
Right.
It's generally longer than just the preoperative dose.
How long typically?
Historically, it was often 7 days or even longer. However, the current evidence, including data from recent large trials like the CEPI-IT trial, which looked at intra-abdominal infections more broadly, suggests that a shorter duration, typically 3 to 5 days, or maybe up to 7 days in some guidelines, is often sufficient once adequate source control has been achieved surgically. The trend is towards shorter courses, usually guided by the patient's clinical improvement, resolution of fever, normalization of white count, return of bowel function. However, a longer duration of antibiotics might still be needed for patients with incomplete drainage of an abscess, those with persistent intra-abdominal catheters, those who develop post-operative complications like another abscess, or if there's clinical uncertainty about the complete resolution of the inflammation. It requires careful clinical judgment.
Let's talk about specific patient groups now, starting with the youngest. Almost 1 in 8 children undergo a workup for appendicitis at some point, making this a very common concern in pediatrics. And it presents unique challenges due to their developing bodies and sometimes difficulties in communication.
Indeed, pediatric appendicitis has some key differences. Infants and very young children, unfortunately, are most likely to present with perforated disease already established. Rates can range from a high of 51% up to even 100% in neonates.
Why so high?
It's largely thought to be due to delays in diagnosis because they can't articulate their specific symptoms as clearly as older children or adults. Their signs might be more vague initially. School-age children and adolescents, while still certainly at risk, tend to have lower perforation rates, more similar to adults. While most age groups demonstrate symptoms similar to adults, that migrating pain, fever, anorexia, neonates can uniquely present with less specific signs, such as just generalized abdominal distension, feeding intolerance, and lethargy or irritability, making diagnosis even more challenging in this very young population.
Are there tools to help quantify the risk in children, similar to scoring systems used in adults?
Yes, the Pediatric Appendicitis Score, or PAS, has been developed and validated. It's similar in concept to the Alvarado score used in adults and helps quantify the likelihood of appendicitis based on clinical findings. It's typically a 10-point scale with maximum weight given to findings like right lower quadrant tenderness and pain elicited with cough, percussion, or hopping. A score of 7 or greater on the PAS indicates that the child has a high chance of having appendicitis, with reported probabilities ranging between 78% and 96% in various studies. This helps guide clinicians on whether to proceed directly to surgery, obtain imaging, or observe the child further.
And just like in adults, ruling out mimics is crucial in kids. What are the key differential diagnoses to consider in the pediatric population?
Special considerations must always be made to exclude several relevant conditions that can mimic appendicitis in children. These include intussusception, where one segment of the bowel telescopes into another. This often presents with intermittent, severe colicky pain, vomiting, and sometimes those characteristic current jelly stools, and possibly a palpable abdominal mass. Gastroenteritis, the common stomach bug, is another frequent mimic, though it often presents without the significant leukocytosis or the sharply localized tenderness seen in appendicitis. Malrotation with midgut volvulus, a congenital abnormality where the intestine twists on itself, cutting off blood supply, is a true surgical emergency that can present with sudden onset severe pain, bilious vomiting, and sometimes pain out of proportion to physical findings. Must be ruled out urgently, especially in infants. For adolescent girls, ectopic pregnancy and ovarian torsion are critical exclusions, just as in adults. Mesenteric adenitis, that inflammation of abdominal lymph nodes often following a viral illness, is very common. And less commonly, torsion of the omentum, the fatty apron in the abdomen, or even testicular torsion in boys presenting with referred abdominal pain are surgical emergencies that need prompt diagnosis. A thorough history and focused exam, sometimes aided by imaging, are vital to distinguish these.
When it comes to management in children, especially for early, uncomplicated appendicitis, is laparoscopy also preferred?
Yes, definitely. For early appendicitis in children, laparoscopic appendectomy is generally the preferred approach. Numerous studies have shown better outcomes compared to open techniques, mirroring the adult experience with benefits like less postoperative pain, shorter hospital stays, faster return to normal activities, and improved cosmesis.
What about complicated cases in children, like perforation?
For complicated appendicitis in children without a large, well-formed abscess or phlegmon, urgent appendectomy is generally advocated rather than initial non-operative management. And here again, laparoscopic appendectomy appears to retain its benefits over open surgery, even in the presence of perforation, in experienced hands. In cases where perforation is found during surgery, postoperative antibiotics are continued, typically for at least 3 days and preferably 5 days, or until the child is clinically well, following guidelines like those from the American Pediatric Surgical Association, APSA. The management of perforated appendicitis with contained abscess in children is generally similar to adults' initial fee antibiotics, and consideration of percutaneous drainage if feasible, followed by interval appendectomy is a common approach, although some centers advocate for early laparoscopic appendectomy and washout even in this setting, showing it can be safe.
Has non-operative management with just antibiotics been studied specifically in children too?
Yes, it has. Following the trend in adult studies, it may be a safe option for a select group of children. The criteria usually include those with early presentation, typically less than 48 hours of symptoms, evidence of only limited inflammation, for example, WBC count less than 18,002 ml, the absence of an appendicolith on imaging, as these are associated with higher failure rates of non-op management, and no signs of rupture on imaging. Patients managed non-operatively usually receive IV antibiotics until their inflammatory markers normalize and they are clinically improving. Then they transition to oral antibiotics to complete a course, similar to adults.
And how well does it work in kids?
While this approach can be quite effective initially in reducing inflammation and avoiding surgery up front, with success rates reported between 88% and 92% in selected cohorts, there's still a significant recurrence rate, around 22% at 1-year follow-up. Furthermore, it often leads to increased overall resource utilization due to potentially longer initial hospital stays, multiple clinic visits for follow-up, repeat imaging, and potential readmissions for failed treatment or recurrence later on. So again, while it's an option, the trade-offs regarding recurrence and resource use must be carefully considered and discussed with the family and the surgical team. Laparoscopic appendectomy remains the standard for most children.
Moving to the other end of the age spectrum, older adults, they present a unique challenge when it comes to appendicitis, often with sort of diminished inflammatory responses compared to younger patients, right?
That's exactly right. This blunted inflammatory response can unfortunately lead to a more frequent presentation with already advanced disease like perforation or abscess formation. Their bodies may not mount that typical vigorous inflammatory response with high fever and sharply localized pain early on, which can delay diagnosis and allow the condition to progress further before they seek medical attention or before it's recognized.
And they often have other health issues too.
Precisely. Such patients are inherently at a higher risk for complications from both the appendicitis itself and any necessary surgery, largely due to their premorbid conditions, existing health issues like heart disease, lung disease, diabetes, or other chronic illnesses that impair their ability to tolerate infection and surgery. This makes it particularly prudent, even more so than in younger adults, to obtain definitive diagnostic imaging, usually a CT scan, before taking these older patients to the operating room whenever possible. This preoperative imaging helps to confirm the diagnosis definitively, assess the severity and extent of the disease, 4G perforation abscess, and importantly, rule out other serious conditions that might present similarly in this age group, like diverticulitis or even malignancy. Getting the diagnosis right up front is crucial for optimizing their care and planning the safest approach.
Is laparoscopy still a good option for older patients?
Yes, absolutely. Laparoscopic appendectomy has been shown to be safe and effective in the geriatric population. In fact, it can offer significant benefits, potentially reducing postoperative pain, decreasing pulmonary complications, and shortening the overall hospital stay compared to open surgery in this often frail group. This can contribute to a better and faster recovery for these vulnerable patients.
Now, a particularly challenging scenario. Appendicitis occurring during pregnancy. How common is this?
Appendicitis is actually the most common non-obstetric surgical emergency during pregnancy. Its incidence is estimated at about 1 in 800 to 1 in 1,000 pregnancies. It occurs most commonly in the first and second trimesters. While it's relatively rare in the third trimester or immediately before delivery, antepartum state, it can also occur, perhaps surprisingly, in the postpartum period, particularly in women who had a geriatric pregnancy, typically defined as a maternal age greater than 35 years at delivery.
How does the presentation differ in pregnant patients?
While most of the core clinical features of appendicitis, like right-sided pain, nausea, vomiting, fever, leukocytosis, are similar, pregnant patients can also present with less specific symptoms that might be easily dismissed as typical pregnancy complaints. Things like heartburn, bowel irregularity, increased flatulence, or just vague changes in bowel habits can sometimes be early signs. A critical difference, though, is often found on physical exam. The point of maximal tenderness is usually displaced upwards and laterally from McBurney's point.
Why is that?
As the uterus grows throughout pregnancy, it pushes the cecum and appendix upwards and sometimes outwards towards the flank. So the pain might be felt much higher in the abdomen or more towards the right side or back than the classic right lower quadrant location, depending on the stage of pregnancy. This anatomical shift is key to remember during examination.
Imaging is tricky in pregnancy due to concerns about the fetus. What are the preferred modalities?
You're right, minimizing any potential harm to the developing fetus is paramount. Ultrasonography is generally the preferred initial imaging modality because it's readily available and doesn't involve ionizing radiation. However, visualization of the appendix by ultrasound can be difficult during pregnancy, especially in later stages due to the large uterus obstructing the view. Non-visualization rates can be high, and its sensitivity and specificity can vary widely, reported anywhere from 67% to 100% sensitivity and 93% to 96% specificity, heavily depending on the operator's skill and the stage of pregnancy.
So, if ultrasound isn't conclusive,
MRI is an excellent alternative. It offers high sensitivity around 94% and specificity around 97% for diagnosing appendicitis in pregnancy, similar to CT in non-pregnant patients. And crucially, MRI does not involve ionizing radiation, making it very safe for both the mother and the developing fetus. It's increasingly becoming the second-line investigation if ultrasound is equivocal.
what about CT scans? Are they ever used?
CT can technically be performed in pregnancy, using low-dose protocols and abdominal shielding if necessary, especially if MRI isn't available or feasible quickly. However, the potential risk of fetal irradiation, even if small with modern techniques, often leads practitioners to avoid it unless other modalities are truly inconclusive and the diagnosis remains dangerously uncertain. It's absolutely critical when discussing options and risks with the pregnant patient and their family to emphasize the severe potential consequence of delayed diagnosis or missed appendicitis. The risk of fetal loss is alarmingly high, reported up to 36% if appendiceal perforation occurs during pregnancy.
36% fetal loss with perforation. That's staggering.
It underscores the urgency and the high stakes involved. Therefore, there remains a lower threshold to proceed with surgery in pregnant patients with suspected appendicitis, even if the diagnosis isn't 100% certain based on imaging. An acceptable negative exploration rate, operating and finding a normal appendix, is often considered as high as 20–30% in this population because the risk of not operating on a true appendicitis is so catastrophic.
Can laparoscopy be done safely during pregnancy?
Yes, laparoscopic appendectomies can be safely performed throughout all trimesters of pregnancy by experienced surgeons. Although it's worth noting that some large database studies have suggested a variable but potentially slightly higher rate of fetal loss with laparoscopy, around 7%, compared to open techniques around 3%. The reasons for this are debated, but it's a point for discussion. Techniques are modified during pregnancy, such as using lower intra-abdominal pressures, typically 10 to 12 mmHg, during CO2 insufflation for laparoscopy, which has been suggested to potentially reduce the risk of preterm labor. Careful port placement is also key to avoid the gravid uterus.
Has non-operative management with antibiotics been tried in pregnancy?
It has been proposed and studied to a limited extent, perhaps as a temporizing measure or for very mild cases. However, reported treatment failure rates have been as high as 25% in some series. Given the high risk associated with perforation and potential fetal loss, non-operative management is generally considered a less reliable or desirable option for appendicitis during pregnancy compared to prompt surgical intervention.
What about patients who have ongoing or recurring pain? Some people experience recurrent, lower quadrant abdominal pain that isn't necessarily associated with a big febrile illness like acute appendicitis, but maybe imaging findings suggest some kind of chronic inflammation in the appendix. Is that a real thing?
Yes, chronic or recurrent appendicitis is recognized, although it's less common than acute appendicitis. These patients often describe nagging, intermittent right lower quadrant pain, sometimes over weeks, months, or even years. Imaging like CT or ultrasound might show subtle signs like appendiceal wall thickening, maybe a small fluid collection, or even an appendicolith, but without the florid signs of acute inflammation. These patients often report a complete and lasting resolution of their symptoms after undergoing an appendectomy, which kind of confirms retrospectively that the appendix was indeed the source of their lingering pain.
But should everyone with nagging right lower quadrant pain just have their appendix out?
No, definitely not. It's a crucial distinction that in the absence of objective imaging abnormalities suggesting appendiceal pathology or clear symptoms consistent with inflammation, even low grade, performing a prophylactic appendectomy, just removing a normal-looking appendix in the hope it might relieve unexplained pain, is generally not encouraged or recommended. The potential benefits in such cases are uncertain, while the risks of surgery, anesthesia, and potential long-term complications like adhesions still exist. The diagnosis requires careful correlation of symptoms with objective findings.
Okay, let's shift gears significantly now. Beyond inflammation, what's truly striking, and perhaps a little scary, is that the appendix isn't just prone to infection. It can also harbor something far more serious. Neoplasms or tumors. How common are these?
They are relatively uncommon compared to appendicitis, but certainly not rare enough to ignore. Their overall incidence is estimated at around 1% of all appendectomy specimens examined pathologically. So if you remove 100 appendices for a suspected appendicitis, roughly one of them will unexpectedly contain some type of neoplasm upon microscopic review. Though it's important to note, as you hinted, the true population incidence is not definitively known, as many might go undiagnosed if they don't cause symptoms or aren't found incidentally during other procedures or imaging.
What are the main types of tumors found in the appendix?
The neoplasms predominantly occurring in the appendix fall into a few main categories. Most common are the gastroenteropancreatic neuroendocrine tumors, often abbreviated as GEP-NETs, and historically known as carcinoid tumors. Beyond these, we also encounter various types of mucinous neoplasms, which are characterized by the production of mucus. And lastly, adenocarcinomas, which are malignant tumors arising from the glandular tissue of the appendix lining, similar to colon cancer. These are the primary types we see within this small organ.
How do these tumors typically present? Do patients know they have them?
Often, no. Almost 1/3 of these appendiceal neoplasms, surprisingly, present initially as acute appendicitis. The tumor itself causes obstruction of the appendix lumen, leading to the same inflammatory cascade as a fecalith would. So their discovery is often a complete surprise to both the patient and the surgical team, found only after the appendix is removed during an emergency operation for presumed appendicitis and sent to pathology. Others might be detected incidentally during surgery performed for an unrelated cause, or during imaging like a CT scan or colonoscopy done for other reasons. Unfortunately, some are only diagnosed after they've already spread regionally or distantly. Let's delve into these specific types in more detail, starting with the most common, GEP-NETs, or carcinoid tumors of the appendix. These typically appear as submucosal, firm, somewhat rubbery, yellowish masses within the appendix wall, often located near the tip. As we said, they are frequently detected incidentally during an appendectomy for suspected appendicitis. While generally considered relatively indolent, meaning slow-growing and less aggressive compared to adenocarcinomas, they do have the potential to metastasize, spreading typically first to regional lymph nodes along the ileocolic vessels, and less commonly to the liver.
Can they cause hormonal symptoms, like carcinoid syndrome?
Yes, they can, but it's infrequent with appendiceal carcinoids compared to those originating elsewhere, like the small bowel. Carcinoid syndrome, that collection of symptoms like episodic flushing, diarrhea, wheezing, caused by the release of serotonin and other vasoactive substances from the tumor can occur, but typically only if hepatic metastases are present, allowing the hormones to bypass liver metabolism and enter systemic circulation. This occurs in maybe about 2.9% of appendiceal carcinoid cases overall.
So if a surgeon finds what looks like a carcinoid tumor incidentally during an operation,
No.
what's the next step?
Good question. Upon incidental finding of a suspected carcinoid, the surgeon must diligently evaluate the regional nodal basin along the iliopollic pedicle, that's the main blood supply to the appendix, and nearby colon feeling for any enlarged lymph nodes. They should also thoroughly examine the liver surface for any signs of metastases. The subsequent management then depends heavily on the tumor size, which is a major prognostic factor. For small lesions, less than 1 centimeter in diameter, which thankfully constitute the vast majority, about 95% of all appendiceal carcinoids, a simple negative margin appendectomy, just removing the appendix completely, is usually considered sufficient curative treatment. The risk of metastasis from these small tumors is very low.
What about larger ones?
For larger tumors, defined as 2 centimeters or greater, a formal right hemicolectomy, which involves removing the appendix, the cecum, the ascending colon, and the associated lymph nodes, is generally recommended due to a significantly higher risk of lymph node involvement and potential for distant metastasis. Now, for those intermediate-sized lesions, between 1 and 2 centimeters, there's historically been less consensus, a bit of a gray area. However, current guidelines generally recommend considering a right hemicolectomy for these as well, especially if adverse features are present on pathology.
Adverse features like what?
Things like invasion into the mesoappendix, the fatty tissue attaching the appendix, positive surgical margins on the appendectomy specimen, lymphovascular invasion seen under the microscope, or a high proliferative index, Chi-67 score, suggesting more aggressive behavior. If any of these are present, or if the lymph nodes weren't assessed adequately during the initial appendectomy, a completion right hemicolectomy is usually advised. Additionally, measurement of serum chromogranin A, a blood test that can be elevated in neuroendocrine tumors, is also recommended as a baseline tumor marker and for surveillance after treatment.
Okay, that covers carcinoids, GP, NETs. What about goblet cell carcinomas? You said the old name was misleading.
Exactly. These lesions were once mistakenly called goblet cell carcinoids, which incorrectly implied an indolent, slow-growing behavior similar to typical carcinoids. This is a dangerous misnomer. They are, in fact, now better understood as a distinct entity, sometimes called goblet cell adenocarcinoma or just goblet cell carcinoma. They possess features of both adenocarcinoma, glandular cancer, and neuroendocrine tumors, making them a sort of hybrid malignancy. This distinction is crucial because they generally carry a worse prognosis than typical carcinoids, although perhaps slightly better than pure appendiceal adenocarcinomas. A significant concern with these lesions is their known high risk of peritoneal recurrence. They have a propensity to spread along the lining of the abdominal cavity.
How are these managed if found incidentally?
Given their more aggressive potential and risk of peritoneal spread, if a goblet cell carcinoma is detected incidentally, a systematic surveillance of the entire peritoneum must be performed during any subsequent surgery. If disease spread is present, a peritoneal cancer index, PCI score, which quantifies the extent of peritoneal involvement, must be meticulously documented to guide further treatment. In the absence of metastatic disease found during initial staging, a formal right hemicolectomy is generally considered the appropriate surgical treatment, similar to larger carcinoids or adenocarcinomas, to ensure adequate lymph node removal. Though, again, some advocate reserving this extensive surgery only for tumors 2 centimeters or larger, highlighting some ongoing debate based on limited data for this rarer tumor type.
And lymphomas in the appendix. You mentioned they are rare.
Very rare, yes. Primary appendiceal lymphomas account for only 1% to 3% of all gastrointestinal lymphomas, and they are usually of the non-Hodgkin's B cell type. They are notoriously difficult to diagnose preoperatively because they can cause nonspecific symptoms like pain, or the appendix might just appear diffusely thickened or enlarged on imaging, sometimes with a diameter of 2.5 centimeters or larger, mimicking simple inflammation or another type of tumor. Management typically involves an appendectomy initially, both for diagnosis and treatment of the localized process. This is then followed by appropriate hematologic, oncologic workup and systemic treatment, which might include chemotherapy or radiation depending on the specific type, stage, and grade of the lymphoma.
Then we have the most overtly malignant type, adenocarcinoma. How does this differ?
Primary adenocarcinoma of the appendix is also a rare neoplasm, but it behaves much more like a typical colorectal cancer. There are 3 major histologic subtypes recognized: Mucinous adenocarcinoma, which produces a lot of mucus, non-mucinous or colonic type adenocarcinoma, resembling standard colon cancer, and the adenocarcinoid or goblet cell carcinoma we just discussed, which is sometimes grouped here. The most common mode of presentation for appendiceal adenocarcinoma is, surprisingly, still acute appendicitis in many cases, as the tumor obstructs the lumen. However, patients may also present with other signs suggesting a more advanced cancer, such as new onset ascites, fluid accumulation in the abdomen, a palpable abdominal mass in the right lower quadrant, or sometimes it might be discovered incidentally during a colonoscopy or surgery for another reason.
What's the standard treatment for adenocarcinoma?
The recommended treatment for all patients diagnosed with any subtype of adenocarcinoma of the appendix, regardless of size, is a formal right hemicolectomy. This ensures adequate removal of the primary tumor along with the regional lymph nodes in the mesentery, which is crucial for staging and preventing recurrence. Interestingly, while these tumors have a propensity for early perforation, potentially due to tumor necrosis or obstruction leading to appendicitis, this perforation itself is not clearly associated with a significantly worsened prognosis, unlike perforation in standard colon cancer, which is an interesting clinical observation specific to the appendix. The overall 5-year survival rate for axial adenocarcinoma is around 55%, but this varies significantly depending on the stage at diagnosis, how far it's spread, and the grade of the tumor, how aggressive the cells look. It's also critical to remember that patients diagnosed with appendiceal adenocarcinoma are at a significant risk much higher than the general population for having other cancers as well, either synchronous, present at the same time, or metachronous, developing later. Approximately half of these additional cancers also originate from the gastrointestinal tract, particularly the colon. So comprehensive cancer surveillance, including regular colonoscopies, is absolutely essential for these patients long term.
Let's focus now on those mucinous neoplasms you mentioned. The term appendiceal mucocele sounds fairly benign, just a mucus-filled appendix.
The term mucocele itself is purely descriptive. It just means a dilated, mucus-filled appendix. It broadly describes this appearance, but the underlying cause can range dramatically. It can be due to entirely non-neoplastic pathologies like simple mucosal hyperplasia, overgrowth of the lining, a simple retention cyst due to a blockage or fibrosis. But critically, it can also be caused by a spectrum of neoplastic pathologies, ranging from benign mucinous cystadenomas to low-grade appendiceal mucinous neoplasms, LAMN, which have uncertain malignant potential, all the way to, frankly, malignant mucinous cystadenocarcinoma. This wide range of underlying causes makes precise pathological diagnosis after removal absolutely vital, as the prognosis and treatment differ vastly.
How do these mucocele typically present?
The most common presentation is actually incidental detection, often found during imaging like an ultrasound or CT scan performed for unrelated reasons, or sometimes during surgery for another condition. However, about a third of cases do present symptomatically, often mimicking acute appendicitis if the mucocele becomes secondarily inflamed or causes pressure. Some patients might present with just vague right lower quadrant pain or a palpable mass. On cross-sectional imaging, like a CT scan, you might typically see a characteristic low attenuation, dark, round, well-encapsulated cystic mass arising from the appendix location in the right lower quadrant. Sometimes calcification in the wall can be seen.
Are there imaging features that suggest it might be cancerous?
Yes, certain features raise suspicion for an underlying neoplastic process, particularly malignancy. These include irregularity or thickening of the mucosal wall, the presence of enhancing soft tissue nodules within the wall or projecting into the mucus, and large size. During the initial imaging evaluation, it's also crucial for the radiologist to carefully assess for any secondary signs that might indicate spread, such as ascites, free fluid, which might be mucinous, any subtle signs of peritoneal disease like nodules or thickening on the peritoneal surfaces, or scalloping of the liver or spleen surface, which can be caused by pressure from accumulated mucin. However, it's imperative for you to understand that even with these clues, a reliable diagnosis distinguishing between benign, low-grade, and malignant mucinous neoplasms cannot usually be established by imaging alone. Definitive histological examination after surgical removal is always necessary.
This leads to a really critical surgical principle when dealing with suspected mucoceles, doesn't it? Avoiding rupture.
Absolutely paramount. The cardinal rule of operating on a suspected appendiceal mucocele is surgical excision without capsular disruption. Meticulous, gentle handling is required. The importance of avoiding rupture cannot be overemphasized. Why? Because if the mucocele contains neoplastic cells, especially low-grade or high-grade adenocarcinoma cells, spilling those cells and the mucus into the peritoneal cavity during removal can lead to seeding of the entire abdomen. This intraperitoneal spread of neoplastic cells and mucin is the precursor to the subsequent development of pseudomyxoma peritonei, PMP, a condition where the abdomen fills with thick, gelatinous mucin, often containing tumor cells. Rupture essentially converts a potentially curable localized lesion into a diffuse, challenging, and often devastating peritoneal surface malignancy.
So what should happen intraoperatively if a mucocele is found or suspected?
If a mucinous neoplasm is suspected before or discovered during surgery, it is imperative for the surgeon to systematically examine the entire peritoneum, carefully inspecting all surfaces of the abdominal lining, the omentum, the diaphragm, the bowel surfaces, and the pelvic organs. If any free mucin or suspicious peritoneal nodules are present, a peritoneal cancer index (PCI) score must be meticulously calculated and documented. This score quantifies the extent and distribution of peritoneal involvement, which is crucial for staging and determining prognosis and treatment. Biopsy should also be taken from any suspicious areas, including the mucin itself, to examine for the presence and grade of epithelial cells or neoplastic cells. This helps in accurate pathological classification and guides further management, particularly the decision about needing referral to a specialized center for cytoreductive surgery and HIPEC.
Can laparoscopy be used safely for mucoceles?
Laparoscopic excision can be acceptable, but only under specific circumstances and with extreme caution. It's generally reserved for cases where imaging suggests a simple, homogeneous cyst without suspicious features like wall modularity or signs of extra-appendiceal dissemination, and where the surgeon is confident they can remove it intact. If laparoscopy is used, it's recommended that a surgical stapler be fired across the base of the cecum, well away from the mucocele itself, to ensure a negative margin and prevent leakage from the appendiceal stump. And critically, the specimen must be carefully placed into, and removed within, a protective plastic retrieval bag to prevent any spillage of mucin or cells into the abdominal cavity during extraction through the small port sites. If there's any doubt about removing it intact laparoscopically, conversion to an open procedure is warranted.
What about lymph nodes and further management for these mucinous neoplasms?
In cases where the neoplasm appears confined to the appendix itself, with no mesenteric lymph node involvement seen on imaging or during surgery, and no peritoneal spread, a simple appendectomy or cystectomy if needed for margins, with concurrent appendiceal lymphadenectomy removing the lymph nodes specifically draining the appendix, is generally considered sufficient surgical treatment. The risk of lymph node metastasis from LAM or even well-differentiated mucinous adenocarcinoma confined to the appendix is relatively low compared to standard colon cancer. However, if peritoneal spread is evident upon exploration, then the primary goal shifts. Biopsies from multiple peritoneal sites and comprehensive documentation of the disease burden, the PCI score, become crucial. While an appendectomy is still usually performed if the patient initially presented with acute appendicitis symptoms, attempting suboptimal debulking, trying to remove just some of the visible peritoneal mucin or implants without a formal plan for complete cytoreduction is strongly discouraged. These patients should typically be referred to specialized centers. It's also vital during the initial operation to systematically examine other intra-abdominal structures, particularly the ovaries in women, as synchronous colorectal, ovarian, and sometimes endometrial cancers can coexist in patients presenting with appendiceal mucinous neoplasms.
You mentioned earlier that if the histology in the appendix differs from what's found in the peritoneum, the peritoneal histology usually dictates treatment. Can you elaborate on the classification and treatment framework, maybe drawing from Table 32-4 in SCHWARTZ's? How does this specific diagnosis guide what happens next?
Yes, this is a crucial point because the exact pathological classification, especially considering both the appendix primary and any peritoneal spread, directly guides the often complex treatment decisions. The modern classifications, like the AJCC 8th edition and the PSOGI 2016 consensus, really aim to provide a therapy-directed framework. Let's break down the main categories and typical management based on that framework using Table 30-4 as a guide. First, low-grade appendiceal mucinous neoplasm, LAMM. If it's confined to the appendix, prognosis is excellent. Treatment is a negative margin appendectomy or cystectomy, usually curative. If there's a cellular mucin found just around the appendix, periappendiceal, prognosis is still excellent, low recurrence risk. Treatment is negative margin appendectomy and resection of the acellular mucin. If there are epithelial cells found in the periappendiceal mucin, prognosis is still excellent, but a higher risk of recurrence. Treatment involves negative margin appendectomy and then often peritoneal surveillance, maybe a second look laparoscopy, versus consideration of referral for cytoreductive surgery, CRS and IPEC, especially if extensive. If there are distant epithelial cells or a cellular mucin found in the peritoneum, classified as M1A, low-grade mucinous carcinoma peritonei, or disseminated peritoneal adenomycinosis DPAM. Prognosis is still generally excellent long-term if treated appropriately, but high recurrence risk if not. Standard treatment is referral for CRS and HIPEC, often including appendectomy and omentectomy, removal of the fatty apron. Next, high-grade appendiceal mucinous neoplasm, HAMN. Next, high-grade appendiceal mucinous neoplasm, HAMN. This is much rarer than LAM. It implies more aggressive cellular features but without definite invasion. Prognosis is generally worse than LAM but potentially better than adenocarcinoma. Management is similar to LAM based on extent, but perhaps with a lower threshold for recommending CR-SCHWARTZ due to higher risk. Then, mucinous adenocarcinoma, if confined to the appendix, stage IATIC 1-3, prognosis is very good with adequate surgery. Treatment is a formal right hemicolectomy to remove lymph nodes. If there's peritoneal dissemination, stage 4, classified as high-grade mucinous carcinoma peritonei, sometimes called PMCA, prognosis varies significantly based on differentiation. Well-differentiated has a very good prognosis with CR-SCHWARTZ. Moderately differentiated is good, but poorly differentiated or signet ring cell histology has a much poorer prognosis, maybe 10-20% 10-year survival even with aggressive treatment. Standard treatment for resectable disease is maximal CRS and HIPEC, often combined with systemic chemotherapy, especially for intermediate or high-grade histologies. Also, adenocarcinoma, non-mucinous type, including goblet cell histology. Also, adenocarcinoma, non-mucinous type, including goblet cell histology. Management is generally identical to the corresponding stages of mucinous adenocarcinoma, right hemicolectomy for localized disease, CR-SCHWARTZ considered for peritoneal spread, but often with a greater emphasis on systemic chemotherapy due to its generally more aggressive nature and higher risk of distant metastasis beyond the peritoneum. Finally, very rare serrated adenoma, traditional adenoma. If confined to the appendix, those are considered precursors, not invasive cancer. Prognosis is excellent curative with a simple appendectomy. Finally, very rare serrated adenoma, traditional adenoma. The key message underpinning all of this is that accurate pathological classification of both the appendix tumor and any peritoneal disease is absolutely paramount, as it fundamentally dictates the extent of surgery required, the potential role of HIPEC, and the need for systemic chemotherapy, ultimately determining the patient's prognosis.
That's an incredibly detailed and vital framework. And this discussion of peritoneal dissemination naturally leads us to pseudomyxoma peritonei, or PMP syndrome. This condition is often the end result of those spreading mucinous neoplasms, and it sounds like a truly complex and challenging situation to manage.
It absolutely is. PMP syndrome results directly from the peritoneal dissemination of mucin-producing cells, most commonly originating from an appendiceal mucinous neoplasm, like lamin or mucinous adenocarcinoma. Although, as mentioned, it can occasionally stem from primary tumors in the ovary, stomach, pancreas, or colon rectum. The hallmark is the accumulation of voluminous, thick, gelatinous mucin throughout the abdominal cavity, often associated with diffuse implants of neoplastic cells on the peritoneal surfaces. Its prognosis can vary widely, from potentially curative with aggressive treatment in low-grade, limited-volume cases, to ultimately palliative in patients with extensive, high-grade, or rapidly recurring disease.
For PMP syndrome that originates from the appendix, what is considered the standard of care now?
The standard of care for PMP syndrome arising from appendiceal primaries, assuming the patient is medically fit and the disease is potentially resectable, is now well established. It's a combination of maximal cytoreductive surgery, CRS, followed immediately by hyperthermic intraperitoneal chemotherapy, HIPEC.
Can you break down what that involves?
Certainly. Early detection and management of limited peritoneal disease offer the most favorable outcomes. The surgical technique, CRS, is often extensive and technically demanding. It involves meticulous removal of all visible tumor deposits and mucin from the abdominal cavity. This typically requires performing multiple peritonectomy procedures, stripping the lining of the abdominal wall, parietal peritoneum, and removing involved visceral peritoneum from organ surfaces, as well as potentially resecting involved organs like the omentum, spleen, gallbladder, parts of the bowel, and pelvic organs in women, hysterectomy and oophorectomy, to achieve maximal tumor removal, ideally leaving no visible disease behind, a CC0 or CC1 resection. Immediately following the completion of the cytoreduction, while the patient is still under anesthesia, the HIPEC procedure is performed. This involves instilling a heated chemotherapy solution, typically mitomycin C or sometimes oxaliplatin depending on the center and histology, directly into the abdominal cavity and circulating it for usually 60 to 90 minutes at a temperature of around 41-42 degrees C, about 108 degrees Air. The heat is thought to enhance the penetration and effectiveness of the chemotherapy on any remaining microscopic cancer cells.
That sounds like a very major undertaking.
It is. Historically, SCHWARTZ was considered a highly morbid procedure with significant risks of complications and mortality. However, with increased experience, patient selection, standardization of techniques, and centralization of care in high-volume specialized centers, the morbidity and mortality rates have significantly decreased and are now often similar to those of other major open gastrointestinal cancer surgeries, like a pancreaticoduodenectomy or esophagectomy when performed by expert teams. What's more, for very selected patients with early, low-volume, low-grade peritoneal disease, this combined procedure can even sometimes be performed laparoscopically or robotically, offering a less invasive approach for achieving cytoreduction and delivering HIPEC in specific circumstances. It represents a major therapeutic advance for a condition that was once considered largely untreatable. #tag, general outcomes and complications.
So after all that complexity, let's bring it back to the more common scenario. After a standard appendectomy for acute appendicitis, what can patients generally expect in terms of outcomes and potential complications? Overall, it's considered a very safe procedure, isn't it?
Yes, generally speaking, an appendectomy, especially for uncomplicated appendicitis, is a very safe operation with an extremely low mortality rate, typically well less than 1% in most series.
But complications can still happen. What are the most common ones?
While mortality is rare, adverse events certainly can occur. The most common adverse events are related to surgical site infections. These can be either superficial, affecting just the skin incision, or deep organ space infections, potentially leading to the formation of an intra-abdominal abscess, a collection of pus inside the abdomen where the appendix used to be, or elsewhere. As we discussed regarding antibiotics, for patients with truly uncomplicated appendicitis who undergo a successful appendectomy, no further postoperative antibiotics are usually required beyond the standard preoperative dose. The source of infection has been removed. However, for those who had perforated or gangrenous appendicitis requiring surgery, patients are typically treated with a course of postoperative antibiotics, usually for 3 to 7 days, although recent evidence, like the STOP-EIT trial, suggests that a duration closer to 4 days may be sufficient once adequate surgical source control has been achieved and the patient is improving clinically.
How are those wound infections managed if they do occur?
Superficial wound infections involving redness, swelling, and maybe some pus at the incision site can typically be managed with simple wound opening at the bedside or in clinic, allowing drainage, followed by regular dressing changes, packing, to allow the wound to heal from the bottom up, healing by secondary intention. Interestingly, studies looking at delayed primary closure, leaving the skin incision open initially after a contaminated case, and then closing it surgically a few days later, have generally not shown a significant benefit in reducing surgical site infection rates compared to immediate primary closure, so it's not commonly practiced anymore. In laparoscopic appendectomy cases, these superficial infections usually occur at the umbilical port site, which is often slightly larger than the other ports.
What about the more serious, deeper complications, like an intra-abdominal abscess?
Deep space abscesses, those collections of pus inside the abdomen detected usually by CT scan in patients with persistent fever or pain after surgery, are typically managed with percutaneous drainage. Similar to draining a primary appendiceal abscess, this involves using imaging, CT or ultrasound, to guide the insertion of a drainage catheter into the abscess cavity, combined with appropriate intravenous antibiotics. Reoperation is usually reserved for cases where percutaneous drainage failed or isn't feasible. Other, less common complications can include fistulas, such as an appendicocutaneous fistula, a tract from the appendix stump area to the skin, or an appendicovesicular fistula to the bladder. These are often initially managed conservatively with drainage and antibiotics, allowing time for them to heal, but may require surgical repair later if they persist. And while infrequent, other reported long-term complications after appendectomy can include adhesive small bowel obstructions, where scar tissue causes the bowel to kink or block, and very rarely potential impacts on fertility in women, particularly if there was significant pelvic inflammation or abscess formation leading to pelvic adhesions.
Here's a specific, uncommon complication that surgeons and emergency physicians need to be acutely aware of: stump appendicitis. It's one of those things that can really catch you out if you're not thinking about it right.
Yeah.
A patient comes in with appendicitis symptoms, but says they've already had their appendix out.
Exactly. Stump appendicitis refers to the development of acute inflammation and infection in an incompletely excised appendiceal remnant or stump, specifically when the remaining stump length left attached to the cecum is greater than about 0.5 centimeters. Diagnosis can be particularly difficult precisely because the patient often has a history of a prior appendectomy, making clinicians less likely to consider appendicitis again. It requires a high index of suspicion, careful assessment of the patient's history, maybe the original surgery was difficult or done long ago, a thorough physical exam focusing on the right lower quadrant again, and usually confirmation with imaging studies, typically a CT scan, which can identify the inflamed remnant stump.
So prevention during the initial surgery is absolutely key. How is that achieved? What should surgeons be doing to avoid leaving too long a stump?
To prevent stump appendicitis, it's paramount during the initial operation, whether open or laparoscopic, to clearly identify the true base of the appendix where it joins the cecum. Using what's sometimes called the appendiceal critical view can help. This involves properly orienting the anatomy. Typically visualizing the appendix itself, maybe placed at 10 o'clock position visually. The titania collibrior, those longitudinal muscle bands on the colon, perhaps at 3 o'clock, and the terminal ileum entering the cecum, maybe at 6 o'clock. Critically, the surgeon needs to identify the point where the 3 tentinicola converge on the cecum, as this definitively marks the base of the appendix. The ligation tie or stapler application should be placed flush with the cecal wall at this convergence point, ensuring the entire appendix down to its origin is removed, leaving behind only a minimal or no stump. Careful dissection and clear visualization are key.
So for clinicians evaluating patients with right lower quadrant pain, what's the main take-home message regarding stump appendicitis?
A low index of suspicion, or perhaps better put, maintaining awareness of stump appendicitis is critically important, especially when evaluating a patient with abdominal pain who reports a prior appendectomy. Don't immediately dismiss the possibility. Failing to consider it can lead to significant delays in diagnosis and subsequent complications, like perforation of the stump, which carries the same risks as primary appendiceal perforation. A prior appendectomy history should never be considered an absolute criterion for ruling out acute appendicitis entirely without further investigation if the clinical picture is suggestive.
One last interesting consideration, especially for surgeons operating in the abdomen for other reasons: the practice of incidental appendectomy. This means prophylactically removing a normal-looking, healthy appendix during another unrelated operation, just to prevent the possibility of future appendicitis. It sounds logical on the surface, but is it generally recommended?
It's another nuanced question with specific indications, but not a blanket recommendation. Incidental appendectomy is routinely considered and often performed in specific, defined high-risk patient groups where the potential benefit of preventing future appendicitis is thought to outweigh the small additional risk of removing the appendix.
Can you give examples of those high-risk groups?
Sure. These typically include children undergoing long-term chemotherapy or who are significantly immunocompromised, as diagnosing and managing appendicitis in them can be very difficult and dangerous. Other compromised hosts, perhaps with spinal cord injuries or altered mental status, where a typical appendicitis presentation might be masked or unclear. Patients undergoing surgery for Crohn's disease, but only if the cecum itself looks completely normal and uninvolved by Crohn's inflammation. Removing the appendix can prevent future diagnostic confusion between Crohn's flare and appendicitis. Individuals who anticipate traveling or living in very remote geographical locations without ready access to urgent medical or surgical care. And critically, it's often performed during cytoreductive operations for certain gynecological malignancies, particularly ovarian cancer, where appendiceal involvement is possible or future abdominal surgeries are likely, and removing it simplifies future management.
Okay, so specific situations warranted. But what about for the average asymptomatic patient undergoing, say, a routine gallbladder surgery or hysterectomy? Should their appendix just be taken out while the surgeon is there?
For the general asymptomatic patient undergoing other routine abdominal or pelvic surgery, the practice of incidental appendectomy is currently not widely advocated or routinely recommended by most guidelines.
What's the rationale against it in those routine cases?
The rationale is based on a risk-benefit analysis. While there's a lack of definitive long-term high-quality evidence specifically evaluating incidental appendectomy outcomes in large populations, the potential lifetime risk of developing acute appendicitis for an adult is relatively low, around 7 to 8%. Conversely, even removing a normal appendix carries small but real risks associated with the procedure itself: bleeding, infection, extending operative time slightly. More importantly, any abdominal surgery, including appendectomy, can lead to the formation of intra-abdominal adhesions, scar tissue later on, which carry their own long-term risks of chronic pain or future small bowel obstruction. Some analyses have suggested that the risk of developing complications from an incidental appendectomy, like adhesions, might actually be similar to, or even slightly higher than, the baseline risk of developing appendicitis later in life. Plus, there are increased procedural time and economic costs associated with performing the extra non-indicated procedure. So, for these reasons, an incidental appendectomy for an otherwise asymptomatic, normal-appearing appendix during unrelated surgery is not currently a widely advocated practice for the general population. #outro.
Wow, what a truly deep dive. We've covered so much ground. From its surprising potential role in our immune system, really challenging that long-held belief that it was just a useless vestigial organ, to the intricate nuances of its diseases like appendicitis and those complex neoplasms, and exploring the cutting-edge treatments. The appendix is clearly far from the simple throwaway organ it was once thought to be. It's a really complex, dynamic part of our anatomy with a rich history and, well, an ever-evolving understanding.
Indeed, this exploration really highlights a key point in medicine. Even in seemingly well-understood areas of human anatomy and common surgical problems, there's always more to learn, more complexity to appreciate, and room for our understanding to be refined. Our knowledge is continually shaped by new research, technological advances, and crucial clinical insights, constantly driving medical and surgical advancements forward.
And for you, our listener, you've just gained an elite understanding of this vital, albeit small, part of our gut. We've unpacked its fascinating history, its unexpected potential role in immunity, and gut flora balance. We've journeyed through the intricate diagnostic process combining history, physical exam, lab tests, and advanced imaging. And we've navigated the diverse treatment pathways from antibiotics versus surgery debates to laparoscopic techniques to the complex management of perforation, abscesses, and even those less common but very serious conditions like appendiceal neoplasms and pseudomyxoma peritonei. What's truly fascinating here, I think, is just how much this tiny organ can tell us about broader medical advancements. The shift to minimally invasive surgery, the role of antibiotics, the complexities of cancer treatment, and the constant evolution of our scientific knowledge based on evidence.
So here's a final thought to leave you with. If the appendix, an organ once widely dismissed as useless evolutionary junk, turns out potentially to be a key player in our gut health and immune system function, what other vestigial parts of our body or long-held assumptions in medicine might just be awaiting their own scientific reevaluation? Something for you to ponder until our next deep dive.